Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on pharmacogenomic testing. There's an industry that's cropped up in recent years where companies will examine a person's genes and they'll come up with a report that talks about a given person's genomic profile, and specifically whether they have one variant of a particular gene or another. There are genes that have different forms and they're called alleles. And basically it has to do with how a given individual might process, that is, metabolize a given medication. And so I'll see these profiles, and the point is to suggest which psychotropic agents might be preferable for a given patient based on their genome, based on their genes and the versions of the various proteins, enzymes for example, that are involved in the metabolism of medications, in the liver primarily, but there are a lot of other organs that are involved in the excretion of medications, because when we take in a medication that's an exogenous foreign substance, it doesn't belong in the body. And so as it passes through the liver, it's changed chemically so that it can be excreted. And most medications are metabolized by the liver and they're excreted in the urine. A few are excreted in the urine unchanged, but they can also be excreted in the feces and the lungs and the skin. And so various organs are involved in how a medication is excreted. But what these usually expensive tests show is basically, for example, that one individual is a slow metabolizer of a given medication, meaning that that person may not tolerate that medication as well as the next person, or as well as a different kind of medication. But I have to say, and this is my opinion, not all clinicians may agree, but in my opinion, those tests are of no value at all. Zero value in choosing particularly psychotropic agents. And the reason is that they don't predict efficacy. They can't possibly predict efficacy. We don't know if a given medication is going to help a patient until we try it. There is a certain amount of empiricism in psychiatry, an empirical approach, but it's not necessarily a purely empirical approach. We're not closing our eyes and pinning the tail on the donkey or throwing a dart at a dartboard. I have other videos about this, but there's a methodology to it. And so what we consider are the target symptoms. And then we understand that if we manipulate this neurotransmitter or that hormone or this other chemical, that we're going to get an effect, that we're going to perhaps manipulate a physical threshold, like the threshold for tearfulness, or the threshold for anger, or the threshold for anxiety, for feeling overwhelmed, the panic threshold, or the threshold for somnolence so that somebody can fall asleep. These are different things that we can manipulate. And so we choose a medication with a mechanism of action in mind, and also then consider the most likely side effects for that particular agent in that class, and we compare that against the demographics of the patient. So the patient's gender, age, lifestyle variables, their health status, conditions they may already have, other medications that they're already taking, side effects that we can't afford, that would be deal breakers, or that would be very poorly tolerated in these individuals. So you consider all of those factors, as well as the most likely diagnosis. It's incredibly complicated. And it has to do with a given individual, and you have to consider all of those variables in real time, assuming that you're getting accurate information. So you have to assess that as well, the reliability of the historians, of the reporters, and then also correlating all of that with the examination, with serial mental status exams, objective information, so you can see for yourself exactly what's going on. So these genomic tests are no substitute for all of that. At the end of the day, you're still giving medication and then waiting to see what kind of reaction you get. That said, 99 times out of 100, when an experienced clinician prescribes medication, they can pretty much predict with a high degree of certainty what a given individual's response is going to be. And in terms of tolerability, since that's all really that genomic testing does, is just suggest which patients may better tolerate which medications versus others, that's really a no-brainer. You start with the low dose if you're concerned about tolerability because the person is elderly or because they're very young or because they're very sensitive to side effects or they're already on a lot of medication or they have a certain condition like irritable bowel syndrome that you don't want to exacerbate. Then you just take great care, starting with a subtherapeutic dose. I usually start with a subtherapeutic dose, especially in anxiety. I give the patient a dose I know is not going to be the target dose. Often telling the patient to take it with food to slow down the absorption, dividing up the dosage if necessary, taking it at night. There's all kinds of things you can do to improve tolerability. And you're patient with it. You wait because most side effects that you get early on, patients develop tolerance to. They just disappear with time. And you titrate slowly and you give it time. And that strategy obviates most side effects, certainly the unpleasant ones that would be deal breakers early on, like nausea, headaches, diarrhea. And then based on the target symptoms, and based on how the patient is doing, then you decide how high to take the dosage. Also keeping in mind side effects that don't show up at the lower doses, but that often show up at the higher doses. They can be chronic and they can be deal breakers for a lot of patients, like sexual dysfunction or weight gain. Weight gain is not dose dependent usually, so that's something you usually decide early on and try to avoid in most patients, unless you have a patient who needs to gain weight. But the weight gain itself is not going to become evident until later on. So you really want to head it off at the pass. If you know that a medication increases appetite, and I just did a video on that, so please check that out. You warn the patient about it, and you make sure they're weighing themselves once a week, no more often than that, and you have them be vigilant for an increased appetite so that you can do an about face and change course if after a week or two they gain 5 pounds. So there are side effects that don't quote unquote show up until later on, but really they're there from the start. But all of this is clinical. It's tailored to the individual based on obvious parameters of demographics and lifestyle. And it's based on honest discussions with the patient about what they'll tolerate and what they can't tolerate in terms of side effects, and going from there. You don't have to go and pay a lot of money to get blood drawn, to get a genotype that's going to suggest that you might tolerate this compound better than another. That's a waste of time, in my professional opinion. It's a waste of money. You wouldn't want to not take a medication that you may happen to be a slow metabolizer because of that, because your genome says that you metabolize it slowly. So what? We'll give you a low dose, we'll go super slow, and we'll end up on a lower dose than what we would end up with for other patients who are not poor metabolizers. And you might not be genetically a poor metabolizer, but if I give you another medication that suppresses the enzyme that is responsible for metabolizing that medication, then you're going to get a drug-drug interaction and you're going to be a slow metabolizer for all intents and purposes. But again, who cares? We can do things with dosing and titration to account for that, and that may be the best medicine or the best class of medications for you based on your target symptoms, based on what you need, based on what neurotransmitters need to be manipulated and in what way, what mechanisms of action we're going for. And so you might actually get information from those blood tests that might lead a clinician to disavow those medications when we just need, that's information that's a red herring. It's actually distracting. And so we really don't need expensive tests to tell us about tolerability. And keeping in mind that those tests can tell us nothing about efficacy. Even in terms of efficacy, I can better predict that a patient is going to stop crying or stop being hyper irritable all the time or get to sleep because I'm going to give the right dose of the right medicine. And if they take it properly and they're being honest with me in follow-up, it's going to work. I know that panic attacks will stop. And while I can't predict that a patient is going to go into full remission with regard to their anxiety disorder, and that's going to happen within the month, I can't predict that with 100% certainty. Still, you have a very good sense for what this particular drug at this dosage is going to do in this individual who weighs this much and has this temperament and who has these lifestyle variables. And even though it is an empiric approach, because we just have to try the medication and see what happens, 9 times out of 10, if you're working with someone who's paying attention, who's got the right diagnosis in mind, but moreover who's attending to the target symptoms, then you can be very certain that the symptoms are going to improve vastly or just a little. And so again, while you can't predict that someone, for example, with endogenous recurrent major depression, you can't guarantee I'm going to get you into remission within 4 weeks. That's usually the way it goes. And then we fine tune. And then if there's anxiety, that might take a little bit longer. But I never order genomic testing because it doesn't inform the treatment plan, the treatment rationale, what I'm going to recommend, how I'm going to recommend it, how it's going to change over time, which of course is highly dependent on how the patient responds and what they tell me when they return to clinic, which can't be predicted at the outset, and certainly not with a blood test. A blood test is not going to tell me how to tailor that treatment plan, how that treatment plan should evolve over time based on how the patient does. That's the most important thing. What am I going to do when the patient comes back to me based on what they tell me? And what they tell me is not always accurate. Sometimes I have to debrief the patient, and sometimes I have to point out things and get them to stick with it so that we can accomplish an adequate therapeutic trial. So many trials that patients have had when they come to me, they don't even remember what the dose was or how long they took it, and they just remember that it didn't help. But those are inadequate trials. You have to take the right dose for the right length of time, and for psychotropic medication, even those that work fairly quickly, an adequate therapeutic trial is going to take weeks. That doesn't mean we have to waste weeks taking a medication that's poorly tolerated or that's not going to work, but there's no blood test, there's no x-ray, no biopsy that's going to tell me how to prescribe and titrate a psychotropic medication. Those tests, those studies, in my professional opinion, are a huge waste of money. It's an industry that professes to be able to guide therapy and assist therapy and avoid unpleasant reactions to medications. But all of that can be accomplished by a competent, astute clinician, somebody who knows what they're doing with these medications and how to tailor them, and also how to help patients when they come back and they report that they're not taking the medication anymore. And these are all the reasons why, and they didn't call you so you could address those concerns. There's nothing in that genomic testing that's going to tell me how to handle that situation. The reluctant patient, or the patient whose anxiety is sabotaging treatment, or the person who just wants Xanax and they don't want to take Zoloft because they don't like the sexual dysfunction and the fact that it makes them tired. They're going to come back and they're going to tell you they couldn't take it because XYZ, and they'll exaggerate the side effects and they'll talk about things that they read on the internet. How do you deal with that patient? You don't deal with that patient by drawing their blood and saying, oh, you're right, this piece of paper says, right? That's ridiculous. And also, the last thing I'll say about efficacy is that even if you have the right target symptoms and you choose the right medication, sometimes patients don't get better because the problem is not primarily a chemical imbalance. They may have a personality disorder with maladaptive coping skills and chaotic and dysfunctional interpersonal relationships and poor insight and substance abuse. The problem may be largely exogenous, largely situational. They're not going to feel better because somebody just died. They're not supposed to feel better. They're not supposed to stop crying. Certainly there are instances where you get a complicated bereavement and they're crying too much. They're not stopping, or they're not sleeping, or they're not eating. And so you do want to address that with medication. But there's a lot of reasons why medications fail. And sometimes it's because medication is not the answer. And sometimes it's because the patient sabotages. They have an agenda. and the trial is doomed from the outset because the patient doesn't want to take Prozac and they don't tell you. And so communication, working with an experienced clinician, and adopting a target symptom-based approach that's cautious and gradual, and then really scrutinizing what the patients are saying and working together. Tolerability is easy. It's efficacy that's tricky. But I would not recommend any blood work to try to find the answer to what medication to choose. We're talking about psychotropic medications. And so those blood tests, they're not useful. It's much more important to consider the patient. So those are my 2 cents. That's my personal professional opinion. Not all clinicians may agree with me. I reviewed Stephen Stahl's Neuroscience Education Institute's latest video on that, and it had a more neutral approach, didn't really endorse it, or kind of endorsed it, but that didn't give me any information to contradict the fact that you're only predicting tolerability and you're not at all looking at anything else. And I would be interested if any of you patients out there have had pharmacogenomic testing and it was useful and it did help the clinician select a medication for you and tailor it. I still think it can be accomplished without that information. On Zoloft, for example, the standard starting dose for years was 50 milligrams. And a high percentage of patients are going to get nausea and diarrhea and headaches. I would say, in my experience, greater than 70 to 80% of patients would get one or all of those side effects if you start with 50 milligrams. 100% of them would get diarrhea if you gave them 100 milligrams to start. 100% of them would have nausea, and most of them would get headaches as well. Whereas when you start at 25, as I always do, and you take it with food, then you might get a little bit of rumbling in the stomach. You might get a loose bowel movement. I see that all the time, even with 25. But half the time, I don't know if 50% of the time, but a lot of the time, I don't. And in the patients that are really sensitive, that they're very nervous about taking the medication, they have anxiety to begin with, and I'm really nervous about them, I share their concern because they're going to want to quit, then I give them 12.5, which is not a target dose for anybody. Even in geriatric patients and pediatric patients, the target dose might be 25. That's very low. But the target dose is never 12.5. But I will start with 12.5, like that tiny little green pill that isn't even scored, and I'll have patients snap it in half and take it with food for a few days so that I will have virtually no chance of giving them any of those side effects or exacerbating their anxiety, because sometimes endogenous anxiety gets worse before it gets better when you give a serotonergic agent. So my point is, there are ways of doing it where I don't need to know what I need to know is what other medications they're taking, because there are inducers and there are inhibitors of the enzymes that will metabolize medications that I'm thinking about giving. So I need to know that, and I need to know about the patient's history and their family history. But I need to consider, okay, I'm dealing with an anxious patient here. They could get worse because I'm giving them medication before they get better. That could happen. Plus, their anxiety could sabotage treatment because they're already super reluctant and super worried about taking the medicine. Those things are what I have to attend to. I don't need to know what your genes say, because also your genes could say one thing and the clinical reality could actually be something different. And again, even if your genes say, be careful about these meds, beware, these meds, that doesn't mean we're not going to pick one of those meds, because if I think that one of those meds are going to be best for you because your sister did great on that medication and you need to gain some weight and you're not sleeping and etc., then I'm going to give you this medicine and we will deal with the consequences together. The adverse effects are always side effects. Anyway, I think I've made my point. Thank you for listening, and comments are always welcome.